The traditional ideal of psychiatric care often centers on a sterile environment, clean rooms, professional attire, and a focus on highly intellectual frameworks like cognitive behavioral therapy. It is a model designed for a world of logic and order. Dual diagnosis, severe mental illness combined with substance abuse, acts as two independent geometric loops colliding into a tangled, accelerating knot. When purely intellectualized talk therapy attempts to pierce this knot, the client feels attacked, causing the tangled loops to constrict and tighten further. Under this pressure, many clients regress. They isolate to escape the feeling of being poked at, and their daily functioning collapses. This often manifests as a total abandonment of personal hygiene, where a client simply stops bathing or looking after their physical self. Untangling a mind in this state requires more than a 50-minute exercise in a pristine office. It requires a practitioner willing to enter the mess of a client's daily life to address the reality of their survival. During an assessment for the title of Master Coach, one candidate appears radically out of place. He wears a tracksuit top, apologizes for having lost his teeth to his past, and asks if it's all right to step off camera to smoke a cigarette. When he describes his history, he doesn't use academic terms. He lists his own labels: severe bipolar disorder, lifelong undiagnosed ADHD, and 2 decades of active addiction. This exterior stands in stark contrast to his professional data. Over the last 6 years, he has completed rigorous training in peer recovery and case management, logging over 1,700 hours sitting in clinical containers with highly complex clients. His perceived flaws aren't obstacles to his work. They are his primary tools. The traditional system often struggles to reach the most isolated patients, but his history allows him to stand in the gap where clinical polish fails. The coach manages a specific, difficult dynamic: clients who are intellectually brilliant, some holding master's degrees, but who have become completely incapable of navigating basic societal expectations due to the combination of autism and addiction. To reach them, he employs somatic grounding. This is a pivot away from the intellect and toward the physical. By focusing on the 5 senses and the rhythm of breathing, he helps clients reconnect with their bodies when their minds are overwhelmed. He also utilizes art therapy and mindfulness as alternative nonverbal pathways. These mediums allow clients to engage with their emotions productively without feeling that their thinking processes are being prodded or judged. This methodology isn't limited to an office. It involves living alongside a patient for over a year, taking over the role of caretaking, preparing daily meals, managing the grocery shopping, and navigating the stressors of chores that would otherwise trigger a relapse. For these complex cases, behavioral change isn't achieved through a single cognitive breakthrough. It is the result of the relentless, shared rhythm of learning how to survive side by side, each and every single day. The coach's own history is written on his body. Years of active addiction resulted in a mechanical heart valve and the loss of nearly all his teeth, irreversible physical consequences of his time in the dark. These markers carry an intense societal stigma. Most people in this position experience a deep sense of shame, often choosing to hide their physical scars or cover their mouths when they speak to avoid judgment. However, this practitioner chooses to carry these consequences openly. He speaks with a level of dignity that refuses to minimize the reality of his past, presenting himself exactly as he is. This visibility has a direct impact on the client. When they see a professional who is unashamed of his own survival, it disarms their own fear of being judged. It creates a connection based on a shared lived reality rather than clinical distance. In the trenches of recovery, a flawless exterior can sometimes feel like a barrier. A visibly scarred coach suggests that the person across the table has already navigated the path the client is currently struggling to find. Despite successfully managing hundreds of complex cases, the candidate remains convinced he isn't ready. When asked if he should be certified as a master coach, he immediately says no. This is the mechanism of his imposter syndrome. He views his lack of traditional academic pedigree as a disqualifier, allowing a fear of his own capability to override the reality of his success. He mistaggrizes his work, describing the years he spent stabilizing traumatized lives as just my daily life. Because it was lived experience, he struggles to see it as a valid professional portfolio. The evaluator's intervention is direct. Playing small is not an act of humility. It is a disservice to the community. By hiding behind a perceived lack of polish, he withholds the exact type of empathy and wisdom that his clients need to recover. The challenge for a practitioner with an unorthodox background is to stop waiting for traditional validation. To help those who are still in the mess, they must claim the authority they have earned through their own survival. True mastery in human care isn't found in the absence of flaws. It is found in the courageous integration of our messiest lived experiences into the work of helping others.